as Dr. Fogla said, actually, I don't need a slide to introduce Kamal. I've known him since the early 90s when we studied together in Maulana Azad Medical College for our MS. But Kamal has come a long way, and I need this slide to introduce him. He has been dynamic right from the time that I met him for the first time. Found his way from Maulana Azad to Gangaram, excelled there, and then went on to partner with his friend Dr. Sood, and then set up the Sharpsight centers, of which has again come a long way. Founder medical director of the Sharpsight group, with a chain of 10 eye hospitals and two outside Delhi. Sharpsight also has gone international with centers in Africa, Mongolia, and Tajikistan. And he has been a brilliant surgeon right from the time I knew him. All our teachers thought that he was too fast, and occasionally they were scared of holding his hand back lest he cause a complication, but that was long back. And today he's become a brilliant surgeon, teaching so many people, performed over 70,000 surgeries, and one of the fastest cataract surgeons in the country. He has been presenting papers and invited for instruction courses at almost all the international conferences, the ASCRS, ESCRS, and the world other forums, the AIUS. He is one of the favorites when it comes for being invited to perform live surgeries in India and abroad. He is very passionate about technology, and he has been working with a lot of technology, EMRs, recording devices, you say it, making movies. He has a passion for almost all kinds of technologies, listening, making music for that matter. He has been amazing at mixing music. I love his compositions. He's into sound engineering, also interested in Urdu poetry, photography, if I remember correctly. And so, as I said, I don't need slides to introduce him. Yet, I think, Kamal, it's nice to have you, do this program today. Please go ahead with show us what you're planning to show.
Thank you, Gaurav. And Gaurav, it's always a pleasure to have a session with you, Dr. Rohit, Natasha, Dr. Fogla, Dr. Himanshu. There's so much of cross-learning, and I guess I always end up learning. I keep taking notes. You'll be amazed. I keep taking notes even during the webinars I'm conducting. So, okay, my topic is avoiding keratome-induced Descemet's detachment during cataract surgery. This will be a bit of theory, a lot of videos, and more of practical stuff. So first of all, there are no financial disclosures. I have nothing financial associated with any talk or any products I'll be talking about. So as we all know, Descemet detachment is a very, very uncomfortable situation for a cataract surgeon. He's doing a meticulous job, a perfect surgery going on, and this is what he lands up with. A bullous Descemet detachment can be a big headache. A lot of times you want your cornea surgeon to be around to help you out. You're sweating unnecessarily. And at times it can be of no fault of the surgeon. It could be just a bad instrument. And so what it is that it has been reported to occur at any stage of cataract surgery, but mostly it has been seen related to the wounds or the construction of incisions. Now, Dr. Susan Jacob, in one of her articles in Eurotimes I came across, she's classified these detachments in 2 or 3 major categories, one being the focal DMDs and the second major category being the rhegmatogenous. Now, according to her, the focal DMDs are approximately in 43% of cataract surgeries. Now, most of them can be very small, less than 1 millimeter. You probably won't even notice. I'll show you some videos, which actually since I was supposed to be talking on this. So over the last 2 weeks, I started collecting some videos, and all the videos you see, I've collected some from my archives. So some of them might go unnoticed, but if you look for them, you actually cause that Descemet's detachment either at the side port or the main wound. Now, what you have to be careful is once you created that DD, now you have to be careful that any further aggression near that will lead to a bullous retinal detachment. Now, most common reasons are blunt instruments, suboptimal knives, at times injection of viscoelastic. We'll see some videos for that. Viscoelastic injected within the Descemet membrane and the stroma, intracameral fluid, BSS during hydration. A lot of times they will happen, suppose you are reoperating a case and you create a separate plane in a fibrous corneal wound. Now, the possible situations for a Descemet's detachment could be when we are talking about the side port. If you have a very tight side port, an insertion of instrument or your chopper or your manipulator could actually cause a Descemet's detachment, which could be a focal. A lot of times, a hydroinflation of the side port at the end of the surgery, you could actually enter the space behind the descements and create a bullous retinal detachment. Sometimes the main wound during insertion of the phaco tip, especially when you're dealing with a flared phaco tip, you need to be careful because these flared phaco tips are known to cause more descement detachment near the wound. A lot of times, if the wound is little tight, your sleeve tip can get engaged in the wound. So we will see some videos for that. Insertion of the IOL, a lot of times, so a lot of people are doing a wound assisted insertion or hydro insertion of the IOL, which you'll see in the video. The haptic can actually sweep as it's unfolding and sweep out the descements from the wound. Hydroinflation of the main wound. So as I said, just a minute, I actually rewind the thing. So what are the characteristics of a blade which contribute to a descent detachment is the thickness of the sheet, the sharpness and the angulation, the edge overplay or the edge profiling, and the surface polishing. A lot of times you could have a good blade, but if it's badly polished and rough surface, while you enter into the anterior chamber, you could cause a descent detachment. Now, these are the most probable reasons. As I said, a lot of times this is a repeat. A lot of times there could be inherent weak attachment between the descements of the patient. I still remember I operated a lady, mother of a very senior director in Indian Oil, and I finished the surgery and I just put in a small hydro and I could see the whole descements detach. And I thought it was my fault, there was something wrong. So when I took up the second eye surgery after 3 months, I was very careful while doing the hydro, but I realized that even the slight movements of my instruments within the cornea or the wound was causing a focal descent detachment. This is in spite of the fact that I was super careful. So this means there are some patients who would probably be more prone to have descent detachment. There are a few studies which actually say that what are the kind of wounds which are more prone to descent detachment. This is again a study by Dr. Tityal at RP Center, where he says that most common stromal hydration is 83.7% of focal descent detachments is a stromal hydration. The rhegmatogenous descent detachment is usually seen when there is a mechanical injury due to the instrument or the haptic sweep. But let us all understand, a poorly constructed corneal incision is the first starting of problem during a cataract surgery. We are not only just talking about descent detachment, but leaky wounds, iris prolapse, corneal edema, and all that stuff. So let us look at the architecture of a wound. What could an ideal wound or a good blade or a good keratome help us with? An ideal wound should be as near a square appearance as possible. A lot of times you see a lot of YouTube videos where you see the surgeon sweeping the wound from side to side and trying to compensate for the thicker blade or a blunt blade. And this is what you land up with. You land up with a chevron based appearance of the incision. We will see a video here. Now, this is a classical example. You just see my blade is about to enter and you see a dimpling. And this incision resulted into a chevron incision. Now we will see another video. You see, it's a blunt blade. I'm moving side to side. I do and manage to enter and see what I've created. There is a typical center pouting here. Can you see the central point, Dr. Gaurav?
Yeah, yes, Kamal, I can see it. Yeah.
Now, this is what a chevron incision would look like. A lot of times you would miss it if I had not stained it. If I had not known what I'm creating, I would have got away with this. And at times of hydro, since the inner lip is very thin and the descent is very fragile attached at this particular point in the center, and here at the edge, you could actually create a descent detachment. Now, this is the result of a blunt blade and a side-to-side movement. Now, we will go to the next position. This is another video where you have a focal descent detachment due to a tight wound. I'll try and freeze my video there. Now, can you see a local descent detachment here? Can you see the fold?
Yeah.
And there's a descent detachment here. Now, this is again at the side port. Now, in case the surgeon would not have noticed it and gone ahead with an aggressive hydroinflation or hydrosealing of this wound, he would have landed up with a bullous detachment. Now, this is a bad blade, which the surgeon is attempting in one go and then realizes it's a bad blade, takes that blade away and starts afresh. Now, this is again, we have two planes of tissue. You will notice a movement within the wound of another stromal tissue which has come loose within the wound. Can we see that, Dr. Gaurav?
Yeah, yeah.
There is a loose tissue which is a two-planar wound due to a reintroduction of the blade and not entering in the same plane. The reason why the first blade was pulled out was it was blunt. So this is what a bad blade can do, and this tissue would keep troubling the surgeon all through. Now this is again another wound which is bad constructed. It's a shorter tunnel. It's tight. So see what the sleeve while entering the wound does to the Descemet membrane. Now this will be again a high magnification video. See what happens. The sleeve is tight. It's getting stuck up at the wound. And there. And now see, since I was aware I might have caused some problem, and you will see, I'll freeze the video somewhere in between, and you should be able to see the Descements flapping there. I'll just forward the video. Now you will see the Descements. Now, can you see this fold?
Yeah.
This is what the sleeve did. It was a tight sleeve. The surgeon here is me again, tried to push it through. I was a little aggressive. I could have probably waited or maybe positioned the entry point of my irrigation aspiration pot. But now, since I was aware, I have to be very careful when I insert the IOL in such a situation, because the IOL in the wound assist technique while inserting or even the sweeping of the haptic can actually cause a complete detachment of this Descemet. Now, bad blades give you uncontrolled incisions. A good form could be always that you should have a radial entry. It should go straight in and straight out with no sideward movements. A proper width will give a less astigmatic effect. But a lot of times when the surgeon is moving the blade from side to side, you will have an irregular entry, which is an angle or an oblique. So we will see some still photographs of that. Now, let's see this. A bad blade, once it goes in, this is what it does. It creates a crooked, uneven shape and creates a bevel inside or a chevron-based incision. So this is a chevron-based incision. I hope on the Zoom video it is visible. Can you see the apex of the incision? Dr. Gaurav?
Yeah, I can. Yes.
And this is an oblique incision where the blade was being swept from side to side and you have an irregular entry. Both these wounds not only are scarred, unsightly, but they would also induce astigmatism and be unsteady and unreliable. This is again a video. So I'm just trying to show the bad ones first. This is a blunt blade. You will notice that I need to support the eye from the opposite side to make sure that the blade enters and we create an entry. But though the entry looks normal, but we will see the scar on the eye after a few days. After the second post-op visit, we will see the slit lamp photographs. Now this is the time, a lot of times the patients will have dysphotopsia. A lot of times these scarred wounds which have longer tunnels because of side-to-side movement will cause dysphotopsia to the patient. Because the scar shadow, as I'm moving the slit lamp, you will see that the shadow extends till the pupillary zone. The same goes for this. So again, situations in post-RK where, a blunt wound making incision, you can actually dip in and cause the cornea to open up. This is a DMD post-Descemet attachment. This is again DMD at the wound. Now there are some videos which I took from the YouTube for our audience to see. Now I will just point out, you have to watch out this area. There probably was a small DMD here. The surgeon actually accidentally pulls out the hydrating part of the bimanual irrigation aspiration and just manages to push some fluid into the Descemet space and see what happens. Now watch this area. Everything is fine till now. See, there. The surgeon just pulled out the irrigating part, went into the area where there was a loose Descemet's flap, and this is what happened. Now, this is again another video where there could have been a Descemet detachment at the side port. There, you see a bullous retinal Descemet detachment. So before we do aggressive hydrodelineation, hydroinflation and sealing of the wound, we have to be very careful that there are no Descemet detachments sitting there. Again, visco injection under the Descements will cause this. So there you see viscoelastic has caused this. Now this is a thicker blade with a premature entry, and see what it has done. We have an iris prolapse with a gaping wound. Again, a thick blade. So all these things. Now, how are the blades, good blades, made? Good blades are not manufactured from sheets. They are manufactured from wires. They are compressed by pressing on wires, unlike other blades which are made from sheets after heating them. And as it is told that the sheet, when it is heated, it can cause uneven sharpness and uneven strength. But in money blades, I use a lot of them. I've shifted to money blades. And even for my femtocataract surgeries, I'm using a lot of money blades now, because a lot of times the incision would not open. And even if it is tending to open, I prefer and I feel I get a far more controlled incision with a money blade. They are made by beating and pressing onto the wires. No glare, good polishing, and the surface edge. Now, the trick of these blades is the way they are shaped. They're cross-lapped edge. They are very sharp. They're, I think, as sharp as diamond blades, because I've been using them for probably 1.5 years now, and I'm very happy with these blades. And in fact, most of my femtocataract surgeries, I'm doing using these blades. Now, the difference, the trick lies in the bevel and the profiling and the angulation of the blade. Now, we will see 1 or 2 videos, and that should finish my talk. The edge part. Now, this is a video again with a money blade. Now see, no pressure, no side pressure, and the wound is just clean. Once the wound is made, you can't even spot the wound. How beautifully the wound has been made. The inner lip is distinct. There's no Descemet stretch. Now, this is a high myopic patient. You can see no need to hydrate the wound. I will just use an hydroinsertion. You can see the IOL actually stands vertically in the anterior chamber to show how myopic the patient is. And I will not need to hydrate the wound at all. I will just pressurize the chamber, and that's it. The wound is sealed. I think that's one classical definition of an ideal keratome. So this is another femtocataract which here I'll be using. No pressure, no counter pressure. You just hold and push, and you have a clean, smooth entry. Again, this wound will not require any seal or hydration. Again, we use the hydroinsertion, putting in a multifocal lens, and the wound is not hydrated. It is going to seal. We just insert some fluid into the eye, hydrate the side port, and the surgery is over. So what it does for the patient is the hydration, no need for hydration. The patient has a better vision, a clearer vision, and a faster recovery. So thank you. So Dr. Himanshu.
Yes.
Incisions, importance of incisions.
First, I wanted to comment, brilliant presentation.
Thank you, boss.
One question, it was not only here you were aggressive, overall always you've been aggressive. So I compliment you on that. Of course, if your incision was not good and if your rhexis is not good, your surgery is gone, period. So the first part is the incision. If you don't have adequate space, if it's not the right size, if you don't know your phacoprobe size, it is just the end of your problem. I mean, just the whole surgery will get into a mess. So I totally agree, a smart, smooth blade. You know, classically, all the residents, they get the 4th, 5th, or the 18th case. That is the worst thing that a resident should be getting. Absolutely. They should be getting a new blade. And this is what I keep telling them, you know, because that's the way they will be learning surgery. Or poor children, they get messed up in their surgery because the wound creation is only bad. So the beginning, a good step is 60% job done. and the next 20 with the rexis. So I think the very important that we have a good blade, sharp entry, and don't worry about the cost. It gives you fantastic results, and you'll be more than happy.
Dr. Kishore, any experience and any comments on the blade I just discussed?
Yeah, I mean, I use money blade since last about 3.5 years now, and I mean, I have never felt that I have to change. Or I mean, to be very honest with you, when someone said me that you get an incisions with femto, so I said the incision that I get with the money blades, even your femto cannot give it. They're so perfect. You just go smoothly, just pass it on. It's like how you say that when just going through the butter. It's like that. You don't have to really stress or push it that it is going to go. It just gives you. The only thing is you have to understand that how I mean, you have to just make it like this that you get exactly a rectangular where you don't have to. And I have never so many people who come for a fellowship or an observation. They ask me, so why don't you highlight your main entry? Everyone does it. I said I have never felt the need of doing a main entry dehydroinflation. Side ports you do it because you have the side ports which goes through that and it makes that round tunnel. But in the main tunnel, I've never done an hydroinflammation because I mean that's actually the place where you get the Descemet detachment.
True. Dr. Natasha is there? No, I don't see her. Dr. Fogla, experience with these blades? Oh, she's there. Actually, people are not on screen, so a lot of times I don't know whether they're there or not. Dr. Natasha, you use these blades?
Well, sir, the cataract department is dead, so I think he's given a wonderful justification for it. We don't step on each other's toes.
One beautiful thing, Dr. Fogla, is once I see the patient on slit lamp the next day, in my experience, it's difficult even looking for the incision once you made it with this blade, even on the first day post-op.
Completely agree with all the points that you have made. And we do come across complications of DM detachments, which are referred to us for further management. And often the starting point is a bad incision where you have created a DM detachment, a focal DM detachment, and then subsequently when you go in with your probe or you try to hydrate your wound, you end up detaching the Descemet membrane. And at times, unknowingly, you might even catch the Descemets in your phaco probe or IA probe and eat up a piece of the Descemet membrane, and then you have post-operative diffuse contact.
Yes.
The only one point that I would like to make, even for residents who are in training, is that, see, the tendency when you do a cataract surgery is to make your side ports first. And then you fill the chamber with viscoelastic, and then you go to make your main incision. Now, the trick to get a good incision is that you need to have a firm eye. If your eye is soft, then you find that it takes more pressure to get the blade, especially if your blade is not as sharp as the money blade. The other blades, you have to do a lot of manipulation. Sometimes you have to move the knife sideways to be able to. So that's not the ideal way of the incision that should be made. And often it also makes a very long tunnel than what is desirable. So always pressurize the chamber very well and then try to make your main incision, and you will ensure that you get a proper incision which is of the right dimension and is not larger than what you would have wanted. And even when you go in with your probe inside the eye, don't go with the irrigation on, because if you do have a small detachment because of the fluid flow, you'll end up enlarging that detachment at that point. And if you feel that there has been some, even if there is a partial or a small detachment close to the wound, there is no harm in putting a mid-size air bubble in the anterior chamber at the end of the surgery, because that small air bubble in the anterior chamber, when the patient is sitting up, will ensure that the small partial detachment that you have, it gets secured very well, and your patient doesn't have a focal edema around the incision site, which takes maybe a week or 10 days for it to resolve.
Wonderful. So I guess
Dr. Kamal, there's a question for you. It says, can you elaborate exact movement of the blade? I mean the plane wise, that is straight and down, or up, straight and down?
Okay, I think it's a very good question. I used to make triplanar incisions to start with, where I would have one incision at the clear cornea or just mid-limbus, which is exactly perpendicular to the plane of the tissue. It would go approximately 60% to the depth. And from there, I would follow the plane of the cornea from the limbus. And then just approximately 1.75 millimeters, I would make a dip in. That's what I was making an earlier triplanar wounds. But for last 2-3 years, I've realized a triplanar wound or a good biplanar wound with a good blade is as good, because sometimes when I'm making a triplanar wound, and since most of our surgeries are topical and the patient moves, you can end up making a deeper wound. A lot of times have a chevron incision or probably injure the capsule itself. So I've stopped doing that because a lot of times you have those itchy and jumpy patients. So I make a biplanar wound just at the junction of the tissue. My first incision is perpendicular. Then I follow the path of the cornea, which is approximately 60 to 70% of the depth of the cornea. And then I straight enter at an angle without depressing in the center. But yes, for beginner surgeons, making a triplanar wound is far more a good idea because they are far more sturdy, because then you can actually balance the thickness of the roof and the floor. So triplanar wounds are known to be more sturdy and astigmatic neutral. But over time, as you move, you can shift to biplanar wounds.
Yeah, but, Dr. Kamal, what do you have an opinion about astigmatism within a bipolar and in a triplanar? Because triplanar will give a more astigmatism as compared to a biplanar.
So the reason being the roof of the triplanar is as thick as the base of the floor. If you want, I can actually go back to the cut section which I showed. So the wound holds better. But once you have a biplanar wound, and if you actually overpressurize the eye, the Descemet tends to slip over and underlock. And when it underlocks and then the fibrosis happens, you could probably have more astigmatism. So for a beginner, because for a beginner to titrate the post-operative pressure of what he leaves the eye, if the biplanar wound, the inner lip is thinner, and when the pressure goes up, the inner lip of the Descemet sites can tend to underlock and slip. So this is where you can probably have a flatter meridian. That's in my opinion.
One point regarding the money blades is that they are super sharp. They make beautiful incisions, but they are very, very fragile in the sense if you're not very careful, you can find that by the time she gives you the knife, the tip is slightly bent and you find that it's not performing. So you have to be very careful with that. So I often tell my nurses not to remove it from that casing that it comes.
Yeah.
So I take the casing, I remove it myself and then use it, because they have a tendency to remove it and keep it in the tray. And if it touches any other instrument or any other thing,
it's finished.
The tip gets, so that's the only downside of the money knife.
I completely agree, Rajesh. In fact, exactly my thoughts, because, I often tell them that, don't take off the sleeve and give it to me because, and however, here I would like to point out that all these blades, I mean, the good quality blades, including money, they come with that protection sleeve, which, kind of protects the blade. So I think that's a great thing, which is not available on all the blades.
Yeah, that's from BD. If you see, they have a very nice retractable sleeve. So whenever you're going to use the knife, you can retract it, use the knife. So I think just that it costs a little more. So, but if people who make beautiful blades, if they introduce that concept like a retractable sleeve, so that if you remove it from the packaging.
Rajesh, it's there on money. I use them for a long time, last 2-3 years. Money comes with those things. They're slightly more expensive, but then they tend to last so much longer. We've been using plasma sterilizer, or even
you can always, if the tip is not damaged, you can always
10 patients without realizing it goes still like as it's going through butter.
Yeah,
so I think money has that big advantage. It comes with an even better sleeve than BD. I was using BD for many years till a few years back I switched to money, and I think no looking back, money is fantastic.
Wonderful. Yeah, and with plasma sterilizer, I agree with you, Gaurav, it can be recycled.
Yes.